LR6SO43, right? LR6SO43. As it turns out, there are 6 extrinsic eye muscles, 6 of them that move your eyes. There's a 7th muscle that runs along the top of the orbit that controls your eyelids. I want you to know all 7 of these. And then we want to talk about their innervations and what they do, how they're attached inside, and so that we can talk about the movement of the eye. This is one of those things where you really need to know not only the innervations, but the actions of these muscles. It's very interesting how these things work. Okay, good news. There are really only 2 names to remember for the 6 extrinsic muscles, rectus and obliques, because there are 4 rectus and 2 obliques. So the 4 rectus are named for their locations, top and bottom, inside and outside. We call them superior rectus, inferior rectus, lateral rectus, and medial rectus. Superior rectus across the top, inferior rectus across the bottom, lateral rectus on the sides, medial rectus on the medial side. So 4 muscles. Now it is interesting to note, because I want you to learn this in terms of the eye movement. Your eyes can move in all sorts of directions. Your eyes are not simply muscles that turn. They don't simply go this way and that way, and this way and that way. You can combine these movements to move in any sort of angular direction with your eyes. But in addition to moving your eyes up and down and lateral and medial, you can also move your eyes in the vertical plane. So they can move down like this, and they can move up like that. So the motion of your eyes is exquisitely complex. And if you look at the attachments, so students ask this sometimes. They say, well, why can't I just combine, why could I not just combine the contractions of the rectus muscles and do everything I need to do? And the reason is just that. You need to be able to move the eyes in the vertical plane, and you also need to combat an anatomical phenomenon. And that is the muscles on the top and bottom, the superior and inferior rectus muscles, actually have a tendency to pull the eye medially because of their direction. Now, most texts won't point this out, but as they come off that annular ring, we're going to talk a lot about the attachments. As they come off that annular ring, they actually proceed slightly from a posterior to medial direction, so that when they contract, either up or down, they tend to pull the eye medially. So they contribute to the medial rectus phenomenon. So what we need are some muscles that will combat that and be able to move the eyes in the vertical plane. And that's what the obliques do. As you're going to see this is a difficult part to remember whenever you're memorizing these things. That's why I mentioned it up front. Because the obliques have this lateral motion, and you'll see that in their attachments. All right, so I use this picture to name them, and you can see the trochlea. I'm going to talk more about that in the following picture. So this is the picture I really like to use to describe the attachments. So first of all, let's see, name it here, and then show it in the next picture. So the superior rectus, the inferior rectus, the medial rectus, and the lateral rectus all fuse in the back of the eye in a ring through which the optic nerve also passes, called the annular ring. It has an eponym that I learned when I first learned it, but they don't use it anymore in the books. So we're just going to call it the annular ring here. The annular ring is the attachment of the superior and the inferior and the lateral and the medial rectus. It is also, as you can see in this picture, it is also the attachment point for the superior oblique. So 5 of the 6 attach and fuse into this annular ring. All right. Now, the only one that doesn't fuse into the annular ring is this one, the inferior oblique. So let's look at this on the next picture. Okay, so you can see here, let's take them one at a time, the superior rectus muscle coming, and the picture actually depicts it nicely, I think, with a slight angle medial. See it? A slight angle medial here, the superior rectus. And same thing for the inferior rectus. In the annular ring and working its way. Now, it attaches into the wall of the eye. So across the top and across the bottom. And here are the other two, the medial and the lateral rectus. You can see those fused in there. And you can also see this one, the superior oblique, fused into that annular ring. Now, the attachments of these make good sense. The superior, inferior, medial, and lateral rectus all make good sense. This one right here is tricky. Watch the pathway. Watch the pathway of the superior rectus. It actually passes from the annular ring along the superior and medial wall of the orbit. Do y'all see that? So toward the nose, it's on the top, passing along the top, but it's actually passing to the inside of the rectus. And then there is this very dense, strong fibrocartilaginous ring here. It's got some cartilage fibers in it. Very, very strong thing. It's almost impossible to cut this thing. Called the trochlea. And that trochlea, as you can see here, is actually embedded into the frontal bone. And the tendon of the superior oblique then passes through that trochlea so that this thing actually serves as a pulley. And then it crosses over to attach. It actually, can you see the bend in this thing, how it moves back posteriorly? It actually bends back posteriorly to attach across the eye on the superior and lateral portion of the eye over here. See where the thing is over here? So when this muscle contracts, it pulls the eye in a very funny position. It makes a very interesting kind of motion for the eye. It actually makes the eye go down and lateral. So when this muscle contracts in that pulley, it pulls the eye like this, down and lateral. Now, the inferior oblique, this one down here, this muscle actually attaches down here on the maxilla, in the floor of the orbit of the eye. And this guy moves across the bottom of the eye. You can see it labeled here. Moves across the bottom of the eye to attach also to the lateral portion of the eye. Now, it also moves the eye slightly lateral in the vertical and lateral plane. And when it contracts, the eye actually moves superior. So lateral here and superior. So very sophisticated actions for the movements of the eye with the obliques, the superior and inferior obliques. Now, this is what you need to memorize. LR6, SO4, 3. LR6, SO4, 3. The innervation of the extrinsic eye muscles. What do you mean by 6? Well, you learned the cranial nerves, didn't you? On old Olympus towering top. A, what nerve is that? The abducens, okay? So the lateral rectus is innervated by the abducens. LR6. What is cranial nerve 4? On old Olympus towering. Trochlear. Cranial nerve 4. The superior oblique, SO, is innervated by the trochlear. LR6SO4. LR6SO4. The rest of them, including the levator, which I'm about to show you, are all innervated by the oculomotor. The rest of them are innervated by the oculomotor. So why do I just say 3 at the end? LR6SO4, 3. LR6SO4, 3. What does the 3 mean? Everything else except the lateral rectus and the superior oblique gets oculomotor. Now, how do these nerves get to the extrinsic eye muscles? How do they get there? How do these nerves get to the extrinsic eye muscles? So all these things are tied together, young people. Keep putting them together in your head. So when I told you about when I mentioned to you the muscles of mastication as we started the lecture today, I said the mandibular branch of the trigeminal does this, but the trigeminal has 3 branches. And I said the ophthalmic branch of the trigeminal passes through the superior orbital fissure. But I'm going to remind you in just a moment, cranial nerve 3 and 4 and 6, LR6SO43, pass through the superior orbital fissure to get to the eyes. So if you look in the back of your eye now, in the sphenoid bone, and you see the superior orbital fissure, tell me about the important things that are there. So I want to do sensation, right? I want to know about stuff that's happening in this area. I want to take somatic sensory information to my brain. What nerve would I use to do that? I would use the trigeminal. What branch of the trigeminal would I use? I'm in the eyes. I'm around the eyes. I'm going to use the ophthalmic branch. What if I wanted to bring sensory information from my upper jaw? What branch would I use? The mandibular branch of the trigeminal. What if I wanted to bring sensory information from down here? What branch of the trigeminal would I use? The mandibular branch. How would that information get from here into my brain along the ophthalmic branch of the trigeminal? How does it get through? Through the superior orbital fissure. How does this information here, this sensory information, get through? Through the foramen rotundum. How does this information right here get through? Through the foramen ovale. Are you following me now? Okay, so now I want to now bring the somatic motor information into my eyes so that my eyes can move. What 3 major nerves would I use to bring that information into my extrinsic eye muscles? 3, 4, and 6. Yes? And how do those nerves get there? Through the superior orbital fissure. Exactly. Okay. So that's what I wanted to say about that. Now let me show you a couple more pictures. I like to mention always here the levator or the levator palpebrae superioris. It is not a muscle that moves the eyes. But if I asked you as a young person, if I asked you, how do you move the eyes? Then you're going to answer cranial nerves 3, 4, and 6. I hand you a pencil, and I say, now, there's your patient. Move the pencil in front of the patient's eye. Something is wrong. I'm telling you, something's wrong with the eyes. Move the pencil in front of the patient's eyes and tell me which cranial nerve you think has got a problem. You ought to be able to do that now because you know which ways the eyes move. You know which muscles are doing it, and you know which nerves are controlling it. All right? Now, here's one thing that would jump out at you. It would leap out at you immediately. If your patient had a droopy eyelid. Now, you don't know this, so I'm about to tell you. This muscle right here, the levator palpebrae superioris, its proximal attachment, its deep attachment is not shown, but I'm going to tell you, the levator palpebrae superioris is actually attached to the lesser wing of the sphenoid, right on top of the optic canal. Can I say that? Do y'all know where I am? I don't have to show you a picture of that. And then it moves through the orbit of the eye to attach to the tarsal plate of the eyelid. Now, I thought about that today. I thought, well, I better show them a picture. All right, so this is an extra picture I put in today. It's got a bunch of details on it you don't have to know, but students like to see it, I think. I thought today, before class, I thought, well, maybe they're going to want to see this. I normally just say it. So here's the levator palpebrae superioris right here. What is this muscle right here, young people?
Superior rectus.
Good. Do y'all all see that? That is the superior rectus right there. Okay? Does it make sense to you in this picture? Just encourage you, right? This is a Netter Atlas picture. These are things that you're learning. You don't know how much detail you're actually picking up. Does it make sense to you here that this is labeled the orbicularis oculi? Does that make sense? This is that circular muscle that we learned that goes around the eyes. That's the major muscle that closes my eyes. And you can see how, in what close proximity the fibers of the orbicularis oris are to the actual eyelids here. The eyelids, we refer to them as the palpebrae, the eyelids. Let's try something else here. This labels the superior and inferior tarsus, which is why I pulled it out of the atlas. You can see that there are these dense plates. They're actually fibrocartilaginous plates, very tough plates. You can feel them in your eyelids. Some people can do weird stuff with their eyelids where they take the skin and move it over, and you can actually see the plates, the bare plates in their eyes when they do that. Have y'all seen people do this before? So this muscle here, the levator palpebrae superioris, actually extends down here and connects to these tarsal plates. Now notice also, I'm going to tip you off as to how you would figure this out clinically. There's also a bit of smooth muscle here in the eyelids. And these are called superior and inferior tarsal Mueller's muscles, these smooth muscles, and they're innervated by the autonomic nervous system. This stuff just gets cooler and cooler. Now, if I look at somebody's eye, and one eye, the eyelid is drooping. The first thing I think is cranial nerve 3. The cranial nerve 3 problem. Because I know that the levator palpebrae superioris is controlled by somatic motor fibers in cranial nerve 3. So if there's a problem in cranial nerve 3, I'm going to suspect that there might be some other issues in the eyes, right? Because how many of the extrinsic eye muscles are controlled by 3? 4 of the 6, right. So I'm thinking that eye is going to have some other issues, and I can pick that up real quick with a pencil. Move it in front of their eyes. Follow this pencil, and I can tell you there's going to be some other issues, normally when you got a droopy eyelid. But you can also see here, there's actually a clinical condition called Horner syndrome, you don't have to know that is actually damage to some of the cervical, the superior and middle cervical ganglia and the sympathetic chain. It's a syndrome, a clinical condition, that impacts the sympathetic information that travels into the eyes. And that will also cause the eyelid to droop. You see why? Because there's smooth muscle in the eyelid also. And so that smooth muscle, the tone of that muscle actually helps to keep your eyelids open all the time. The top one is really the only one that matters. So it keeps the eyelid open. So if there's a sympathetic nervous system problem to the eye, it will also cause the eyelid to droop. So I look at the eye, see there's a droopy eye. I think that is either somatic motor problem, and I'm going to pick that up quickly with my pencil. That's an oculomotor issue. Or that's a sympathetic nervous system issue. And here's what else. You don't know this yet, but you're going to learn more of this as you go. The sympathetic nervous system actually controls the size of the pupil. And its job is to make the pupil dilate. So I can also very quickly pick this up looking at the person's eye if that pupil is not the same size as that one. So if I see a droopy eyelid and a difference in the size of the pupil, I know this is a sympathetic issue and not an oculomotor issue. You see how anatomy can run these things out for you? Very quickly, if you know the anatomy, you can come up with explanations for things quickly. All right, that was bonus. We didn't have to do that. All right, the temporal bone now, we started working on a minute ago, so let's talk some more about the temporal bone. The temporal bone, as you guys know, so I'm in my dissection, working my way in. I did my eyes now. I'm going in this side view once again, review some of this information, pick up new stuff. So now I'm inside the skull looking at the other view of the temporal bone from the inside, and this one shows you that the internal acoustic meatus is a hole in the temporal bone, which you knew already. Now this hole has 2 nerves passing through it, cranial nerve 7 and cranial nerve 8. Now if I said 7, right, keep repeating, on old Olympus towering top, a fat I've got cranial nerve 7, which is the facial nerve. Now, if you had to tell me, how does the facial nerve get off the brain and get to the face? Could you take me along that pathway? We did it last class period. The facial nerve passes through the internal acoustic meatus, yes, of the temporal bone, and it exits the skull through the stylomastoid foramen. Yeah. Okay. Now, the nerve you have not learned anything about yet is cranial nerve 8 on Old Olympus towering top 8, that vicious. What's the V for? The vestibulocochlear nerve. Yes. The vestibule means the place for balance. Cochlea means the place for hearing. This is the nerve for balance and hearing. And it passes through the internal acoustic meatus. It is, important observation, one of 3 cranial nerves that are almost exclusively sensory. And we'll learn them as we go. Cranial nerve 1, cranial nerve 2, and cranial nerve 8 are almost exclusively sensory. What is cranial nerve 1? On Old Olympus towering top. On 1 is olfactory. Well done. And that's going to carry smell information. We haven't seen it yet, but that one goes through the olfactory foramina of the cribriform plate of the ethmoid. Yes? Y'all already learned the skull stuff. We're going to do it as we get to it. 2 is the optic nerve. Have you seen that nerve today? Yes, you have seen it in the annular ring in the orbit of the eye, yes? And what hole in the sphenoid does that nerve pass through?
Superior orbital.
No. That's an excellent guess. But cranial nerve 2 does not go through there. 3 does, and 4 does, and 6 does. And the ophthalmic branch of 5 does. Well, where does cranial nerve 2 go through? The levator palpebrae superioris attaches to the lesser wing right at the optic canal, which is located in the lesser wing of the sphenoid, yes? Okay, so where does the optic nerve pass through to the brain? Through the optic canal of the sphenoid. So 1 and 2 and 3 and 4 and 5. Y'all see how this is adding up now? You're able to put the holes in the skull where these cranial nerves pass through. 8 goes through the internal acoustic meatus, along with 7. And it's sensory only. Now we also have carotid canals in the temporal bone. These carotid canals are the pathway, as this image shows you, for the internal carotid arteries. So how does the blood supply get to the brain? Okay, so learn it now. It never goes away. How do you get blood to your brain? This is your first introduction to it. The internal carotid arteries are 2 of the 4 blood vessels. The other 2 are called the vertebral arteries. So here's how you get blood to your brain. 50% of it travels through the internal carotid arteries, through the carotid canal of the temporal bone to go to the brain. That's 50%. That's 2 of them. And you've seen them already. I showed them to you early on in this class. I used the opportunity when I was talking about anastomosing blood vessels to say that the internal carotids and the external carotids, the externals end up as superficial temporals. And they anastomose with the supraorbital, which are terminating branches of the internal carotids after passing through the orbit. So nothing that I'm telling you is not connected to other things. So try to put these together. The vertebral arteries, which I've not mentioned to you before, are the other 2. They're going to come up again before we're done, because the vertebrals pass through the foramen magnum on their way to the skull, on their way to the brain. So the 2 vertebrals come out and turn on the anterior side of the brainstem and become the basilar artery. as they pass through the foramen magnum. So I'm going to do that with you. So how do you get blood to the brain? I take 2 of the blood vessels through the carotid canals of the temporal bone, and I take the other 2 through the big hole in the occipital bone. And that is all the blood that goes to the brain, the 2 vertebrals and the 2 internal carotids. All right? The jugular foramen is also, it's the most posterior opening in the temporal bone, and it is a pathway for the internal jugular vein from the brain passing down toward the brachiocephalix. All right? So I can take blood to my brain through the temporal bone, but I also know that I have to get blood out of my brain, and how do you drain the brain? And the answer is through the jugulars, the internal jugulars, and these blood vessels also pass through the temporal bone. So if you want to talk about blood to and blood from the brain, you got to talk about the temporal bone, the jugular foramen. Now, this hole is also another really important one for nerve supply. So you can see on this picture some other nerves that we're going to talk about in detail as the class moves forward. The jugular foramen is also the opening through which cranial nerve 9 and 10 and 11 pass. So we have lots to say about each of these. Let me ask you, from what you know so far in anatomy, if I say cranial nerve 9, or cranial nerve 10, what did you just think of? That's exactly what you're supposed to think of. If I say cranial nerve 9 and 10, the first thing that should come to your mind is parasympathetic nervous system. 3, 7, 9, and 10. That's what should have hit you. Now let's do a little bit better than that. And then we'll look at the picture and be finished for today. I'm not going to quite get to it, all of it. The glossopharyngeal cranial nerve is involved in some somatic motor stuff, which I'm not going to talk about. You have seen it already on the tongue, right? The posterior aspect. What are the 3 nerves for taste? 7, 9, and 10. Anterior to posterior, 7, 9, and 10. Okay, so that's sensory stuff. So I say that from the posterior third. We also get a little sensory stuff from the middle ear here on cranial nerve 9. And we get information from the carotid sinus, and we have some control of the parotid salivation. Now this right here is on the picture that I showed you for parasympathetic. So I'm going to emphasize that. So here's what I want to emphasize on 9. For now, what I want to emphasize is taste. I want you to remember the taste thing right now. I want you to remember the carotid sinus thing, and I want you to remember salivation. So when you think 9 for me now, let's add pieces to it. Let's add to that taste, salivation, and carotid sinus. Okay, so let's finish with that carotid sinus thing today, and I'll pick up the other 2 here on Monday. Listen carefully, this is so important. So very important. When I showed you the supraorbital artery picture going up to the head, on purpose I showed you a picture there that had the blood stuff all the way down into the neck. And I said, look, you see the carotids going up there? The carotids are going to split, and the internal carotids are going to go up through the temporal bone, up through the carotid canal. That's how you get blood to your brain. The external carotids are then just going to go to all these external structures, and later in your life, I will teach you all the branches. Sometimes a little fat or picante makes super tacos. This is how we'll remember the branches of the external carotid. Now, where the blood vessels split, where the external and internal split, just very close to this angle. Remember I showed it to you. Not far, a couple of fingers down from the angle of the ramus. There's a little pocket there called the sinus, the carotid sinus. And that is a location in the human body where information about blood gases and about blood pressure is detected. There are really 2 places in your body where this happens. At the carotid sinus and at the aortic arch. So how is your brain receiving information about blood gases? And how is it receiving information about blood pressure? A lot of that information, not all of it, but a lot of it is on cranial nerve 9 coming from the carotid sinus. So this will be a big deal in physiology. I'll mention it again. How are you getting this peripheral information? Why are you breathing? How are you controlling your blood pressure? Cranial nerve 9 is an important part of that puzzle. And it passes through the jugular foramen of the temporal bone. When we get together next time, I'll do the same thing with 10 and 11, and then we'll continue to move forward in our dissection.